Hello, my name is Doug Burgoyne, and welcome to today's webinar, Breast Cancer, Evaluating and Integrating New Treatment Approaches. This webinar is delivered in partnership with MedPage Today, ASCO Reading Room, Train, AVAHO. This activity is provided by Prime Education through educational grant support from AstraZeneca Pharmaceuticals, Aveo Pharmaceuticals, Bayer Healthcare Pharmaceuticals, Merck Sharp and Dome, Novartis Pharmaceuticals, and Segan. Our expert faculty presenting today's webinar are Dr. Colonna and Dr. Mizell. Dr. Colonna and Dr. Mizell, would you please take a moment to introduce yourselves?
Sure, I'm Sarah Colonna. I'm a breast medical oncologist at Huntsman Cancer Institute, also at the VA in Salt Lake City, but I also do work with the National VA and give care through NTO.
Excellent, welcome.
Excellent. And my name is Jane Mizell. I'm a breast medical oncologist at the Winship Cancer Institute at Emory University. And I spend a lot of time thinking about the different things we're going to talk about today. So I'm really looking forward to sharing and having a dialogue with all of you.
Beautiful. Thank you, Dr. Mizell. Dr. Colonna, we look forward to hearing from you today and know that we have a great webinar planned for our audience.
Hi. It's cool to see where everybody's coming from. Okay, so just a bit of general information on breast cancer. Very common diagnosis overall. But as most of you guys know, incidence of breast cancer is increasing by about 0.4% per year, particularly among young people, which is, we don't totally understand why that is. However, good news is death rates are falling by about 1.3% each year, probably due to better detection and for sure better treatments, which we're going to explore all of that today. The story about breast cancer in the VA is a little bit different, actually, just mostly because of the kind of people that choose to go into the military, a little bit different than other people. So breast cancer overall is pretty rare still throughout VA. However, for women diagnosed with cancer, it's the most common cancer at about 30%, obviously much more rare in men. We'll explore that a little bit later. Thinking about what puts people at risk for breast cancer, I like to really think about these in two categories. So non-modifiable, our family history, our genetics. And I actually think about, when you start your period and pregnancy and breastfeeding, those are largely non-modifiable risk factors. When I'm in clinic, I really try to focus on what's modifiable. So what kind of diet are people eating? What's their weight? Are they taking alcohol, which of course increases breast cancer risk? So I try to focus on the things that women have some control over. And more good news in breast cancer, right? So most people diagnosed with breast cancer are going to do really well. They're going to be cured. So overall 5-year survival for all stages is 91%. Of course, women who are diagnosed with metastatic breast cancer have a much more limited 5-year survival at 6%, although there are many women with breast cancer who can do really well for many, many years. So zoning in a little bit more in the VA, the fastest growing demographic in the VA are actually women. By 2040, it's predicted that women veterans will be 17% of the veteran population. That is a really big difference if you've ever worked in a VA. So because of this, the White House and the government has really tried to put a priority in making sure that we are ready to take care of these women in the best way possible. And that's part of a group that I'm part of called the BGSOE. Of course, it's the VA, we have an acronym. So the Breast and Gyn-Onc System of Excellence, which includes Med-Onc, Surg-Onc, Gyn-Onc, and other experts who think about breast and gyn cancers. So that both includes us taking care of people in a virtual format across the country, but it's also really focused on making sure that each particular VA is more prepared to take really good care of these women when they come through the door. So thinking specifically about breast cancer among men. So when we looked at breast cancer diagnosis inside the VA, in general, we think of about less than 1% of all breast cancer diagnoses occur in men. But inside the VA, about 11% of all breast cancers occurred in men. So those of us that are in the clinic, we actually see that quite a lot. Largely, it's the same. Breast cancer among men is the same as among women, except for a few things. Men tend to be older when they are diagnosed. They're more likely to have disease that's metastatic to the lymph nodes or more advanced presentation. And they're much more likely to have estrogen, progesterone positive disease. We also think about they're more likely to have a germline mutation that's predisposing them. So all men with breast cancer for sure need to be tested for germline mutations. Treatment is largely the same. I mean, we're having to extrapolate mostly from clinical trials that include very, very small numbers of men treated for breast cancer. The big difference, I think, is when it comes to hormone therapy use, and this is both in adjuvant and metastatic disease. Aromatase inhibitors do not work in men like they do in women, we think. So because of that, we either give aromatase inhibitors coupled with a GnRH analog like Lupron, or we opt for tamoxifen or maybe a SERD like fulvestrant, that is an estrogen degradator. So that's the primary difference when you're treating men and women with breast cancer. Aside from the really different psychological component, I think this is sometimes harder for men to understand why they've been diagnosed with breast cancer. So drilling down into biomarker testing or molecular testing in breast cancer, thankfully, this has been an area of great growth in the last few years. And that's because we now have treatments. We have drugs that we can use to target many of these mutations that we're looking for. So there's what I like to think of as like sort of the OG personalized treatment. So ER, PR, and HER2. Of course, this should be tested in all diagnoses of breast cancer, men, women, whoever. And this drives much of how we decide to do treatment. But there are newer molecular tests that we should be looking at for patients. So PD-L1, looking at that in patients who have triple negative disease, is becoming more important and helps direct therapy. That will be explored later by Dr. Mizell. And then a pretty new set of mutations. So PIK3CA, now we include AKT1 and PTEN mutations because we have drugs that specifically target those mutations for women who are in the metastatic setting. Of course, we've known about BRCA1 and 2 for a long time, but there are many other germline mutations that we probably should be testing for in most people with breast cancer now. PALB2, CDH1, there's a whole list of those mutations we need to be looking for. And then I think kind of the newer genetic test on the block is ESR1. This is a distinct mutation. It's different from the others because it tends to arise after women have been treated with hormone therapies for years. And it's also different because we will test for it repeatedly during their treatment because it will be normal and then it will turn positive and make them a candidate for new drugs, which will be discussed later. And there's more of these coming, which is really good news. So just thinking about the different ways that we test for these molecular markers. So ISH, or what we used to call FISH, is really looking for specific DNA sequences. And this testing is done usually done off of breast tissue or solid tumor tissue. And we usually use this technology to look for HER2 expression in women who are 2+ positive, and we want to really determine whether they're HER2 positive or negative. PCR testing, which is a way of looking directly at the DNA. And this is also done usually off of cancer tissue. And this is how we look for some mutations. However, most of the way that we are assessing for these mutations now is next generation sequencing, NGS, right? So this has come down dramatically in cost the last few years, and it's really fast and really very effective. So this is the way that we are often doing both germline and somatic testing at this time. This can be done off of tumor samples for somatic testing. It can be done off of blood or saliva for germline testing. I know this should just be a basic standard part of anybody experienced with breast cancer these days, really. And on the right, you'll see this is how we look for BRCA mutations, other germline mutations, PIK3CA, AKT, PTEN, and other mutations. And of course, IHC is not really genetic testing. It's actually testing the protein, which is expressed from the genetics. And this is what we're used to looking in tumor board, where the pathologists look at the staining and give us a sense of how ER and PR positive these tumors are. So the technology, which I think will just be growing in use as we go, is circulating tumor DNA. So trying to look at DNA that is circulating in the blood. This will be more useful in patients who have more tumor burden, so larger amounts of cancer on the scans. This is going to evolve over time how we use this. The way that I think about how to use this now is in patients, for some reason, that we can't get a sample of their tumor. They can't undergo a biopsy, or we just can't get to it. Or maybe they only have a tumor in the bones, which is hard to biopsy. So in patients that need repeated biopsies and it's difficult to get tissue, this may be the best option. Also, this is going to be more useful in ESR1 testing. We know that liquid is a good way to get that information. So HER2 low, whether this is like a new kind of breast cancer or not, is heavily debated, but it's definitely a new way that we think about whether women are a candidate for treatment. So in the old days, HER2 0 and 1+ were considered negative. HER2 3+ is considered positive. 2+ we further figured out with ISH or FISH testing. But now we know, and we'll talk about this more, but T-DXd is a treatment that's approved in women who are what we call HER2 low. So this is either being HER2 1+ or 2+. It's not really a new entity of breast cancer per se, but another way that we determine if they're a candidate for this new, very, very effective breast cancer treatment. So women who are hormone positive or more likely to be HER2 low, but there's still a great proportion of women that are triple negative, 37% of them that can be candidates for this drug. So this sort of depicts in picture what I was talking about. So the old paradigm, HER2 positive 3+, HER2 negative 0, and then patients who are in between 1 and 2 are considered HER2 low. And this is a way that we now consider women who could be treated with T-DXd, this new therapy, which we will talk more about. Okay, so question. How often do you currently test for HER2 status? Options A, at the time of diagnosis, B, at time of diagnosis and also at the time of recurrence, option C, at time of diagnosis, recurrence, and progression to metastatic disease, or option D, at time of diagnosis, recurrence, progression to metastatic disease, and treatment resistance.
Outstanding. Thank you, Dr. Colonna. For our audience, please take a moment to make the selection that you think best answers this question for your practice. The poll has now popped up on your screen in a little gray box. Once you click the selection that you think is best and click submit, then we'll be able to receive the responses and track those for us. Dr. Colonna, it's interesting. I'm interested in the discussion that we'll have after this and what folks think about when HER2 status should be tested. So I don't want to bias anything. I'm going to ask you to hang on before we say anything while we wait. And I'll just remind our audience that Dr. Mizell and Dr. Colonna are interested in answering your questions. So please ask those via the public chat tab. And we'll give our poll. Poll has closed. Okay, 27%. We'll make it back up. 45% of our audience say option D, at the time of diagnosis, recurrence, progression to metastatic disease, and treatment of disease. Second is option C. And then we have some folks that also say A and B. So let's have some discussion about this. What do you think? D, C, B, A?
It's a challenging one. I think in some ways B and C are similar. Like a lot of times recurrence means metastatic recurrence. And so checking HER2 at the time of diagnosis and at the time of recurrence, I think at a minimum would be sort of what I would recommend doing. Cancer sometimes can change from the time of initial diagnosis of breast cancer to recurrence, especially if recurrence is years later. So I think repeating ER, PR, and HER2 at that time is helpful. And I think we'll get into this a little bit more as we talk about HER2 low disease and what that means, and in terms of the treatment options it opens for metastatic patients. But because now HER2 status really is not just positive or negative, but is a little bit more of a continuum, it is sometimes helpful to check it not just at initial diagnosis of metastatic disease, but once patients become resistant to certain treatments. Because even if they were HER2 negative before, if they become HER2 low, they can be a candidate for now HER2 low directed therapy. So I kind of err towards D myself these days, but I think there are multiple ways to interpret this question.
Yeah, same. I don't feel like there's exactly a wrong answer. And I always ask, is their HER2 status really changing, or is the pathologist reading the slide differently? And I guess it doesn't really matter, but we just want to give our patients a chance to have all possible good therapies. And that's why we keep looking at this HER2 over and over, I think.
Yeah, absolutely.
And breast pathologists are not plentiful in the VA. So often we are having to go back and ask them to restain for some of these things. That's something they do really commonly.
Yeah, I think that brings up a good point too. It is helpful, I think, to the extent that you're able to have a relationship with your pathologist so that you can talk through some of these nuances. And if you're ever feeling like a patient's clinical status is really depending on whether or not they can use one of these HER2 low directed therapies, it's not a bad idea to get a second eye on the path slides if you feel like that's needed.
Outstanding. That's really great. Dr. Colonna, walk us through the VA pathway for testing.
Yeah, so this is kind of trying to simplify, if it's possible, genetic testing for breast cancer. So we already talked about how all men with breast cancer should be tested for germline mutations, but the VA is a little unique in their stance that they just say any person diagnosed with breast cancer should have access to germline testing. I think everybody will sort of come along and that'll eventually become the standard. So anybody diagnosed with any stage of breast cancer should have access to germline genetic testing, which is like a breast panel of a number of genes, not just BRCA1 and 2. Of course, IHC, ERPR, HER2 should be done on every biopsy, in any breast cancer sample, because that's really important to figure out treatment options. And then for earlier stages or, curable ER and PR positive breast cancer, many patients should have testing with a genomic assay to help stratify whether they're a good candidate for chemotherapy or not. Generally, that's Oncotype DX because it has the most robust prospective data. And that's a little bit of a discussion trying to figure out if your patient's fit for chemotherapy, but Oncotype DX should be available for our patients inside the VA. And then anybody diagnosed with any kind of metastatic breast cancer should have access to not just germline testing, but also full somatic testing. So we can figure out if any of those targeted drugs could be a good fit for them. PIK3CA, the PARP inhibitors, lots of different therapies now. And the special category probably would be thinking about women who have metastatic triple negative breast cancer. So they need all of the above, right? So germline and somatic testing, but they also need to be sure that they have PD-L1 testing, since that helps define whether they should be candidates for immunotherapy or not. So I think these slides about molecular testing are going to go on the back of the pathway at the VA, and they're trying to get a little more detailed about exactly which labs and how to order to really give that guidance inside the system. I hope that's helpful for people.
That's outstanding. Thank you. Dr. Mizell, anything to add on testing and the appropriate pathway?
No, I think this is a really nice summary. I think the only thing I would add is that some of our patients now, because people can do well for a long time in many situations with metastatic disease, it sometimes is appropriate to repeat some of that next generation sequencing testing as patients progress past multiple different treatments, just because sometimes as the cancer ebbs and flows in response to treatments, new driver mutations can actually pop up. So I do have patients in my practice where I've done somatic testing, and the biopsy platforms like Guardant and Foundation are making it a lot easier to do that for patients without actually having to get new tissue. So a lot of progress that I think we can be excited about.
And I kind of skipped past ESR1 testing. What's your strategy for testing that? How often do you do that?
ESR1 is one of those mutations, unlike PIK3CA, which is usually present at diagnosis if it's going to be present. ESR1 absolutely can evolve and kind of emerge in response to therapies, especially AIs over the long term. So I typically don't necessarily check it at initial diagnosis of metastatic ER-positive breast cancer, but I'll check it after progression on first-line AI and CDK, or if a patient is diagnosed with metastatic breast cancer after a long history of exposure to AIs in the adjuvant setting. I think and we'll talk about this a little bit in some of the slides to come, but the reason why there's so much focus on this testing now as opposed to like 3 years ago is that we now actually have an approved drug called elacestrant for ESR1 mutant ER-positive breast cancer. And so in situations where I feel like that drug would be appropriate to offer to patients, or where I feel like an ESR1 directed trial would be appropriate to offer, that's kind of more where I'm thinking about this. So I could also have a patient where, they've had slow progression even on a few lines of therapy, but if I feel like elacestrant would still be a relevant drug for them, I might perform that testing again at that time.
Outstanding. Thank you. We've had excellent discussion. To our audience, if you have questions or comments, please submit those via the chat. And Dr. Mizell, I think we'll turn the time over to you.
All right. I think that question about the elacestrant and the ESR1 was a very nice segue into hormone-positive breast cancer. There's a lot of updates here and so much we can say about this subtype of the disease. So we'll kind of launch right in. First, we'll talk a little bit about endocrine therapy and some of the updates for patients with early stage breast cancer. As many of you know who've treated patients with metastatic ER-positive breast cancer, this disease has really been changed by the advent of CDK4/6 inhibitors. First palbociclib, which was approved in early 2015, and then followed by ribociclib and abemaciclib. We've really seen patients do well for a long period of time after initial diagnosis. And like any good treatment that gets approved in the metastatic setting, we start to ask the question of, would this be an appropriate medication to give patients in the early stage setting. So there have been 4 big trials that have looked at the question of, can we use in patients with high risk early stage disease CDK4/6 inhibitors in combination with endocrine therapy to improve outcomes. And I'll show you some of this data as we go, but basically Monarchy, which looked at abemaciclib for 2 years in the adjuvant setting, and Natalie, which looked at ribociclib for 3 years in the adjuvant setting, were both positive studies. Meaning they improved outcomes for patients. And so we currently have approval for abemaciclib in this setting. We don't yet have approval for ribociclib, and we'll talk about that. But in your clinical pathway for patients who have tumors greater than 5 centimeters, grade 3 disease, and node-positive breast cancer, we can actually add abemaciclib along with endocrine therapy. So that does represent a change, and I think it's something to think about in your clinical practice. And of course, with more treatment come more side effects too. And so thinking about how we monitor and optimally manage patients who are getting this sort of more intensive therapy. So these are the results from Monarchy and Natalie. You can see Monarchy on the left, which was the study that looked at patients with high-risk node-positive breast cancer, ER-positive breast cancer, and randomized them to receive endocrine therapy alone or endocrine therapy plus abemaciclib for 2 years. And you can see that the invasive disease-free survival at 4 years was significantly improved, both statistically and in terms of just clinically significant percentages of improvement, about 6% better outcomes with the addition of abemaciclib. And then in the Natalie study, you can see that after 3 years of treatment, you do see also an improvement, statistically significant with a good-looking p-value and a confidence interval that does not cross 1, but a little less clinically significant in terms of the numbers, about 3% of IDFS benefit at 3 years. And I think we'll need longer follow-up, of course, for both of these studies, but particularly for Natalie, because in the first report we had from this study, 80% of patients were still on their drugs, so we hadn't yet completed the 3 years of therapy. But these are both really, great trials, interesting outcomes, and Monarchy represents such a drug that we've already had the chance to really put into play for these patients and make a difference in terms of outcomes and hopefully lives long-lived. Interestingly, also, though, were that there were the phase 3 trials looking at palbociclib, the third CDK4/6 inhibitor, also in this setting. And what these trials, both Pallas and Penelope, found was that patients who were hormone positive and HER2 negative, high risk, treated with adjuvant palbociclib for 2 years after standard chemotherapy if desired, and then along with endocrine therapy, did not experience improved disease-free survival. So palbociclib will not be a drug that gets carried forward in the early stage setting, but these other drugs definitely potentially can. So that represents a move forward, and I'm happy to answer questions if people have them about how to optimally manage early stage patients on CDK4/6 inhibitors, since we are recommending that more and more and seeing more and more of those patients in our practice. And then moving on to stage 4 disease, which I think is also, always a moving target. And we've had so many interesting advances in the past couple of years. So for stage 4 ER-positive, HER2 negative breast cancer, we often are getting germline and genomic testing. Patients should have germline testing just so we understand whether they've got a BRCA mutation or other mutation that might impact treatment down the line. And if they are newly diagnosed, then in your practices at the VA, they're usually getting a anastrozole and abemaciclib. I think that's the CDK4/6 inhibitor of choice, or fulvestrant and abemaciclib if they've had anti-estrogen therapy, including AIs, recently in the adjuvant setting. Of course, there are other endocrine therapies as well and other CDK4/6 inhibitors. We've listed those below. The ribociclib and palbociclib are options from a CDK4/6 standpoint. And then patients can get also exemestane or letrozole if they don't tolerate anastrozole, potentially. There are other recommended medicines as well, and we've talked a little bit already about elacestrant for patients with ESR1 mutations, and I'll go into some of that data a little bit further. And then there are other things that we can give patients as they progress on these frontline therapies. So these are the trials, and I think you guys will have these slides to access afterwards, since we may not have time to go into this in too much detail. But these are the 4 big trials that looked at CDK4/6 inhibitors in first-line treatment for hormone-positive, HER2-negative advanced breast cancer, and led to the approval of these 3 CDK4/6 inhibitors in this setting. This is looking at overall survival as well as progression-free survival. You can see that both, really all 4 trials and all 3 drugs showed a significant PFS benefit, both in terms of statistical significance and also clinical significance. If you tell a patient that you're likely to live for a little bit more than a year without progression, as they did with aromatase inhibitors alone, versus a little bit more than 2 years without progression, that's a big clinical difference, and it really has made a difference in our patients' lives. But then when you look at overall survival, and part of the reason why palbociclib may not be as preferred of a CDK4/6 inhibitor for some to date, is that the other 2 drugs, the abemaciclib and ribociclib, we've seen a survival benefit, but we have not seen an overall survival benefit in patients who received palbociclib, at least not in randomized studies. There are some real-world studies that show benefit to palbociclib in the frontline setting for metastatic disease, and so I think the jury is maybe still a little bit out on that in the minds of some. But for those who are purists, ribociclib and abemaciclib may be the preferred CDK4/6 inhibitors in this setting. I think toxicity, though, is an important thing to consider, and that's one of the things that we have to think about when we think about which drug to give, because these patients are going to be on these drugs for a long period of time, an average of 2 years, sometimes more, sometimes less. And I think the important things to pick out here are that neutropenia is far more common in palbociclib and ribociclib, whereas diarrhea is far more common in abemaciclib. So we just have to make sure that we're counseling patients appropriately on what to expect and checking labs appropriately to make sure that we're dose reducing if necessary for neutropenia. And then there's some that are unique to each drug. So abemaciclib carries a slightly increased risk of venous thrombosis or pulmonary embolism. So we have to think about that in patients who may already be at risk for PEs for other reasons. And then ribociclib carries a risk of QTC prolongation in about 10% of patients. And so we're getting EKGs at diagnosis at 2 weeks and 4 weeks on these folks. And this can also be sort of more of an issue in patients who have other concomitant medications that may increase the QTC interval. So just something to think about and to talk about with your pharmacist and also monitor with your patients. Those are kind of the main things that we think about when we think about side effects. And then I think just as with aromatase inhibitors, some patients will tolerate one drug better than the other. Some patients may tolerate one CDK4/6 inhibitor better than another. So it is always worth talking about the fact that there may be options depending on where you are and what you have access to. And so then subsequently, what do? The patient's done well on their AI and their CDK4/6 inhibitor for quite some time. Then you have progression of disease, and what are your options? So it used to be just that, you would give fulvestrant or you would move on to capecitabine if you didn't have another option. But we've had just an explosion of therapies in patients with endocrine-sensitive disease still, and also targeted therapies to sort of help make patients stay endocrine responsive or stay on pill-based therapies as long as possible. So it's really been an exciting few years in this realm. Basically, when patients present with progression on frontline therapy with a CDK4/6 inhibitor and endocrine therapy, that's when I would start to look for molecular targets. So either with biopsy of a lesion, if a lesion is available for biopsy and is not too difficult to arrange, or very easy to just do targeted testing via blood-based testing in the office. So using Guardant or Foundation or other liquid-based ctDNA to look for molecular targets. I think BRCA always comes to the forefront because we want to know about family risk, we want to know about risk of other cancers, but also important because for patients who have a germline or somatic BRCA mutation, they can be candidates for treatment with a PARP inhibitor. Olaparib has been approved in this space, and so has talazoparib for those who have access to that PARP inhibitor. For patients who are not BRCA mutation carriers, you want to think about ESR1. We'll talk a little bit about ESR1 and what that does in terms of eligibility for elacestrant. But then also, if you have a PIK3CA mutation, you can be a candidate for fulvestrant plus alpelisib, which was one of the first PIK3CA targeted therapies available. We'll talk a little bit about other treatments as we get further down the line, but there are other options as well for these patients. And then for patients who have received prior fulvestrant, you can think about everolimus and exemestane. Everolimus is an oral mTOR inhibitor that can be actually very well tolerated along with aromatase inhibitors. And then if people have not had prior fulvestrant but don't have other targets, you could do fulvestrant along with everolimus as well. So a lot of different options for these patients. And then I think we're thinking about capivasertib or CAPI for short, which was studied in the Capitello trial published very recently, and showing benefit along with fulvestrant in patients with PIK3CA mutations, but also AKT1 and PTEN mutations. So really kind of broadening the targeted therapy options for these patients. This is just diving into some more of the evidence. So looking at PIK3CA mutations and then patients with ESR1 mutations. So where does that data come from in approving these new agents? Two different trials, two different drugs. So let's talk about them one at a time. SOLAR-1, we've got over on the left, and this was a trial that looked at patients who have advanced hormone-positive breast cancer who've progressed on an aromatase inhibitor with or without a CDK4/6 inhibitor. So very real-world population at the time. And these patients were randomized to receive fulvestrant plus a placebo or fulvestrant plus alpelisib, which is that PIK3CA targeted pill I mentioned. And what we found was that adding alpelisib increased the overall response rate, doubled it essentially, and really almost doubled the median progression-free survival as well, from about 5.7 months to 11 months. Overall survival was numerically better, but not necessarily statistically better. But this did represent an improvement for patients with this mutation. So the drug was approved for patients with PIK3CA mutations in this trial. And then the EMERALD trial was published even more recently, and this was a trial looking at patients with ER-positive metastatic breast cancer who had progressed beyond one line of endocrine therapy and a CDK4/6 inhibitor. So almost everyone in this trial had a CDK4/6 inhibitor as well. And these patients were randomized to receive either fulvestrant or an AI, whichever drug they had not received already. And then elacestrant was the experimental arm. And you can see that in all comers, elacestrant actually outperformed fulvestrant and AI. But in ESR1 mutated patients in that cohort, the difference was even more stark, with a 40.8% 6-month progression-free survival rate versus 19.1% in those who did not receive the ESR1 targeted elacestrant. And then if you look at 12-month PFS, so looking out even further, more than a quarter of patients who had the ESR1 mutations and were randomized to elacestrant were still on the drug at 12 months, which is actually pretty impressive when you think about what this is, which is really a very well-tolerated pill, versus only 8.2 months of 2% of patients who received fulvestrant and an AI alone. So this drug was approved for patients with ESR1 mutations, and again, is a pill that is pretty well tolerated. Looking at toxicities again, this is going back to alpelisib and to SOLAR-1. This is a drug that can be very good for patients, but can also be very hard, unfortunately, to tolerate. Some of the more challenging side effects are hyperglycemia and diarrhea, as you can see here. Hyperglycemia is one of the ones that really can land people in the hospital and be very challenging. And so this drug is actually not recommended to be given to anyone who has diabetes already. And for those who don't have diabetes, we're actually monitoring blood sugars pretty frequently, every week for the first 2 weeks, and at least once monthly with an A1C every 3 months. And I've definitely had to start patients on metformin to get them to tolerate this medication, and I've had them checking their sugars at home. And then with diarrhea, I think just important to let patients know this is a common side effect, so that if they experience diarrhea, you can get right on it and get them antidiarrheal agents. Then with EMERALD, it was actually a pretty well-tolerated drug. So cholesterol is important to monitor. You're supposed to check a lipid profile prior to starting and periodically. But high cholesterol is often pretty easy to treat with a statin. And then for the other side effects, nausea is one that's sort of unique to endocrine therapy. We don't usually see a lot of nausea with endocrine therapies, and we do sometimes see it with this drug. But in practice, I really haven't had to do much more than give people an as-needed Zofran or Compazine to take occasionally. And then musculoskeletal pain is one of the ones that we're sort of used to seeing with endocrine therapy, and that also can be seen with this agent. But it does tend to be pretty well tolerated, and so for those who respond, it's a great option. I mentioned briefly the Capitello trial, which was a novel study published very recently, looking at capivasertib or capi plus fulvestrant versus placebo plus fulvestrant in patients with hormone-positive breast cancer that progressed beyond an aromatase inhibitor plus or minus CDK4/6. And you can say that this also improved progression-free survival compared to fulvestrant on its own, so kind of similar to the alpelisib data. I think one of the differences here is that this drug does tend to be a little bit easier to tolerate. You don't see the same significant hyperglycemia with capi that we do with alpelisib, so I think a lot of people are optimistic that this drug may be one that can maybe be easier for patients to tolerate and provide better quality of life. Diarrhea is still significant and something we have to talk about with these patients. And rash can be a challenge. This is also a drug with kind of a unique dosing schedule. It's 4 days on, 3 days off. So something where you have to make sure that your patients are comfortable dosing medications in a sort of alternative way and can be compliant with this at home. I think oral medications have been great for our patients for many reasons. One of the challenges is we have to make sure that they can take them and are compliant with them. So that's one of the things with this drug, but as we start prescribing it for more and more patients, we'll have to think more about. But again, great to have the option. And then for patients with endocrine-resistant breast cancer, there are also new options. So for patients who progress beyond all the endocrine therapies, all the endocrine-targeted therapies, what can we do? So for patients who have already received a line of chemotherapy, in addition to all those endocrine therapies, we now have different options. So for patients who are HER2 low, either IHC 1 plus or 2 plus, and have received the chemo, we can actually give them TDXD or trastuzumab deruxtecan. I'll show some data for that in a second. And then for those who have received trastuzumab deruxtecan and have received another line of chemotherapy, we actually also have the option for sacituzumab govitecan. And SASI is an option for patients who have received TDXD and are HER2 low or who are HER2 zero. It's approved for any endocrine positive treatment resistant patient. So it's nice to have these two antibody drug conjugates as options. And then, of course, there are a number of chemotherapies that you can use for these patients with variable response. So we'll talk a little bit about that. And I think there's always that question, too, of like if you've been through multiple lines of treatment, you may not be as responsive to the next line, and you also may be weaker, and it may be more challenging to give chemotherapy. So there's always that question of when do you decide to pull back and pursue a more exclusively palliative approach. These are tough conversations and conversations that I know we are all used to having. And then bone metastases, I know you probably all know this and do this regularly, but we do recommend either zoledronic acid or denosumab every 6 months or sometimes more frequently, monthly or every 3 months for patients with symptomatic bone disease. And then radiation for symptomatic bone mets can also be considered. So what about these antibody drug conjugates? Where's the data there? So Destiny Breast 04 was a really ambitious and fantastically designed trial looking at trastuzumab deruxtecan, which had previously been approved for HER2 positive breast cancer. It's a HER2-directed antibody drug conjugate for patients with HER2 low disease. So these are patients who are ER positive or ER negative, who had IHC 1 plus or 2 plus disease for HER2, but were FISH negative. And these patients had to have received 1 to 2 prior lines of treatment in the metastatic setting. And what this trial found is that for patients with HER2 low disease, both their progression-free and overall survival were better with trastuzumab deruxtecan as the next line of treatment versus physician's choice chemo. And this went for hormone receptor positive patients as well as all comers. So for patients who had previously been designated as hormone positive, HER2 negative, or triple negative, they might now actually be designated as hormone positive and HER2 low, or as hormone negative HER2 low. As you can see, these were statistically significant as well as clinically significant differences. And actually, when this data was first presented at ASCO in 2022, it led to one of the rare standing ovations in the conference room because this data was felt to be so significant and so practice-changing for so many women. So very exciting and something that I put into play almost every day in my clinical practice. Some of the challenges with this drug in terms of toxicities, nausea is very common and fatigue is very common, so we counsel patients on this. We often will give a lot of antiemetics along with the treatment and then also antiemetics to go home with. I've often given dexamethasone 4 milligrams twice a day for 3 or 4 days after treatment just to sort of stave off the nausea and fatigue and help patients get back on their feet after treatment. And I have some patients as well who get fluids once or twice in between cycles if they really struggle with the fatigue and with appetite. The more rare but more severe side effect to warn patients about and to monitor for yourself is interstitial lung disease. Almost all the trials looking at this drug do show about a 10% rate of interstitial lung disease. And there aren't that many things that we know of as risk factors for developing ILD with this drug. One that has come to the forefront is pre-existing kidney disease. So maybe something to be a little bit more suspicious of in your patients who have pre-existing chronic kidney disease. But the way that we look at this is by basically checking a chest CT at least every 12 weeks, if not more commonly, and then counseling patients that if they develop a new cough or shortness of breath, to let us know in between treatments. It's not something that they should wait on and just report at their next visit. They should let us know immediately. And then once we identify ILD, whether it's based on symptoms that prompt imaging or just imaging that we're doing for restaging or for screening, we actually should pause the drug. Consider steroids if patients are symptomatic. And then if patients are asymptomatic, if it's grade 1 interstitial lung disease, just on the scans, you actually can watch and 6 weeks later, repeat imaging and re-challenge with a lower dose of TDXD if the patient is doing better. But for patients who have symptomatic ILD, which we define as grade 2, if they're short of breath or have cough, you're really not supposed to restart the treatment. So definitely an important thing to think about and something that we do watch for in our patients. Blood count abnormalities are a little bit less common in this drug, but we do see it sometimes. And I have had to occasionally give growth factor for patients who are neutropenic on TDXD. And then left ventricular dysfunction is much rarer, but it is something that we look for, and we should do an echo before patients start the drug and periodically during treatment. I usually do it every 3 months to begin with and can sometimes space those out if patients are doing well on the drug with no heart failure symptoms. And then what about the sacituzumab? We mentioned that as well. And many of you may be familiar with the TROPiCS-02 trial. This is a trial that looked at sacituzumab govitecan versus chemotherapy for patients with hormone-positive breast cancer who received at least 2 prior lines of chemo and no more than 4 prior lines. So an ambitious study, because this was being done in patients with very advanced hormone-positive HER2-negative breast cancer, patients who had received a lot of chemotherapy. So you can see here that the overall response rate was increased some, from 14% to 21%. The median PFS was increased some, just by about 1.5 months, but it was statistically significant. And this slide doesn't show this data, but if you look at 6-month, 9-month, and 12-month progression-free percentages, like how many patients, what percentage of patients are progression-free at those time points, that's when the curves really start to diverge. And I think a lot of this is because many patients, being this heavily pretreated, sort of fell off right away, weren't going to respond to anything. But those that made it to 6 months, 9 months, and 12 months did see improvement with sacituzumab. So it is certainly an option for these patients, and one that we often do put into play for those reasons for patients who've received 2 prior lines of chemo or more. In terms of toxicities, neutropenia is one of the main toxicities we see with this drug, along with nausea and diarrhea. This can be very well managed with dose reduction, or for me, sometimes what I've done is actually space out the infusions. This drug was approved as a day 1, day 8 out of a 21-day cycle. But I find sometimes for patients who struggle with their blood counts, if you give it day 1 and 15 of a 28-day cycle, sometimes even along with long-acting growth factor, you can prevent patients having to come back and being turned away because they are neutropenic, and it's just a little bit more efficient for the healthcare system. So that is one option. And then in terms of diarrhea, I actually have not had to use atropine, but you could use atropine if diarrhea is severe. But for most patients, we just use Imodium, and that is enough to manage this. So that was a lot of information. I'll let you guys digest that, and definitely happy to take questions in the chat or afterwards. And then we can let Dr. Colonna move on with talking about treatments for HER2-positive disease.
Yeah, so as is apparent, breast cancer is not breast cancer. There's really different types, and that really drives how women do with them and also how we think about treatments. So we're going to pivot now and think about HER2-positive breast cancer, which is less than, about 15% of breast cancers are categorized as HER2-positive. So this is 3+ or 2+-ish positive. We know that these breast cancers are more aggressive and historically have had worse prognosis, although now with really good HER2-directed therapies, it's probably a wash, which is a great success. It means that we have really made great strides in this kind of breast cancer, which was terrible. One of the toughest parts about HER2-positive breast cancer is that often in metastatic disease, women and men will develop brain metastases, which is obviously a huge quality of life issue and really scary for patients. So a lot of the treatments try to incorporate that into consideration. So this is thinking about women who have HER2-positive disease that's early stage. So we're still trying to cure this cancer. I'll go through a few of these trials briefly. Some I think are really useful, others not. So the first one is looking at neratinib, which is used adjuvantly. And this was an older study completed in 2009 and looking at about eight years of follow-up data. Doesn't show much difference in overall survival. Now, a lot of these women probably got other therapies in there, so that probably makes it difficult to interpret. And also neratinib has a lot of toxicity, mainly diarrhea. So I don't find that this is really frequently used in practice, although it is an option. It is something that sometimes patients will ask about. And if they want to try it, despite the toxicity, sometimes I'll do that. Other trials that have really been practice changing is the TRAIN2 data, which was looking at whether you need to include an anthracycline or you don't have to include an anthracycline in neoadjuvant treatment for HER2-positive breast cancer. So it's really, they looked at epirubicin, but any kind of anthracycline compared to probably TCHP, which is really commonly given. And as you can see, the 3-year PCR rates, or the PCR rates were almost identical, and the 3-year event-free survival were really very similar. So this has driven most people to think that you do not need to use an anthracycline in the treatment of early-stage HER2-positive breast cancer. We tend to lean on TCHP or either TH in really, really early-stage HER2-positive breast cancer. And then the Catherine study, which actually got some press at San Antonio because they released the final data. So Catherine was looking at women who were given neoadjuvant chemotherapy and then went to surgery. So women who did not have all their disease go away, so they didn't achieve a complete response. Should those women go ahead and get trastuzumab or should they get a different treatment, so 14 cycles of TDM1? And the 3-year invasive disease-free survival was significant. So women who got TDM1 were much less likely to have had recurrent disease, 88.3% versus 77%. And then the 7-year overall survival data was recently released, and it was almost a 5% improved overall survival for these women. So this is something that I most certainly use in practice. If women have not achieved a PATH CR, I try to get them on TDM1 if they can tolerate it. And then the Affinity study was looking at the addition of pertuzumab to chemotherapy and trastuzumab for women who had high-risk HER2-positive disease. And this one's been a little trickier to interpret. Overall, the numbers look pretty similar. So you can see the 3-year invasive disease-free survival is pretty similar, 94.1 versus 93.2%. And disease recurrence was pretty similar too. However, when you drill down into the subgroup analysis, it appeared that women who had node-positive disease probably derived most of the benefit from this treatment. So if you had node-positive disease, was 89.9% versus 86.7% invasive disease-free survival. So for this reason, most of us use pertuzumab in patients who have node-positive HER2 breast cancer. But there's some debate around whether you should use pertuzumab in everybody or not. So this sort of leads to the pathway that we use at the VA. So this is in women who have advanced or metastatic HER2-positive breast cancer. The backbone of treatment. So to the left of the screen should be a taxane. We've chosen docetaxel, but docetaxel, trastuzumab, and pertuzumab should be the front line. I think that eventually will go away. There will be different front lines up there, but for now, that's what it is. And if women have received that and say adjuvantly and they've recurred very quickly, then we will move on to another therapy within that year. But if it's been a year since they've received those drugs, then we will often treat them again with that in the metastatic setting. And then we will move on to TDXD. So part of the difficulty, and it's a great problem to have, is there's been a lot of movement in this space, and these drugs have been approved at the same time. So it's hard for us to put them in sequence. So we're using the best clinical judgment we've got. So that's what the pathway reflects. So this is looking. So Dr. Mizell talked about this drug in the HER2 low setting, but this was first approved and used in the HER2 positive metastatic setting in Destiny Breast 03. So again, really impressive numbers that this drug put up. And this was when it was compared to TDM1, which at the time, very briefly, was the standard of care, second line. So 28.8 month median progression-free survival compared to 6.8 months. Overall survival difference at 12 months was 94% versus 86%. And at 24 months, those numbers largely held, so 77.4% versus 69. So for this reason, TDXD, for the most part, is the second-line standard for these women who are diagnosed with HER2-positive metastatic breast cancer. And importantly, we also think this drug has great efficacy in women who have brain metastases. That more information is coming out around that, but that's a really important thing for most of our patients to think about when they're sitting in front of us in the clinic. So Dr. Mizell already referred to this, but one of the special side effects that we think about is interstitial lung disease. And again, that's mostly picked up by scanning, but also just us asking and making sure our patients are aware that this is a unique side effect, and just having a high level of suspicion for the side effect in women. We were all scared by the couple patients that died from the side effect on the trials. So difficult question is how to sequence all of these really great therapies that we have. So again, a taxane plus trastuzumab, pertuzumab is first line. I think maybe it's important to consider brain metastases for these patients. The HER2 climb regimen, which we'll talk about some in a minute, is really very active in brain metastases, and would probably be the first thing that I would go to for these patients. And then you have TDM1 as an option. Obviously, we want women to be exposed to all of these good therapies over time, so it's just a matter of how to put them first, second, and third, really. And then there are a host of chemotherapies or kind of chemotherapy combinations that can be tried after these more effective, newer, and much more expensive drugs are used. So we'll talk about a couple of the trials around this, but neratinib and capecitabine You can couple trastuzumab with many chemotherapies, and those can be options for women who haven't seen those chemotherapies before. And then there are also considerations for women who maybe don't want to do chemotherapy, so trastuzumab and lapatinib. So looking specifically at tucatinib in these patients, so the HER2 CLIMB study, which looked at trastuzumab, capecitabine, plus or minus tucatinib, and the overall response rate was much better in women who received the 3 drugs, 41 versus 23%. And the overall survival was statistically significant, 24.7 versus 19.2 months. And importantly, in the subgroup that we're often very interested in these patients, so women who have brain metastases along with other disease in their body, this drug appeared to be really, really effective for them. So it's clearly getting past the blood-brain barrier and is a meaningful thing for women. It was an exploratory analysis in a smaller group of women that only had brain metastases on this trial. And the outcome, which is intracranial confirmed overall response rate, so looking at the neuroimaging with these women, was much more likely to be improved when you added tucatinib to the combination. Also, the CNS progression-free survival was much better in tucatinib, 9.9 months compared to only 4.2 months. And then the median overall survival was really different for women who received the HER2 CLIMB with tucatinib, 21.6 months compared to 12.5 months. Of course, this number is small. This was not designed to do this, but it gives us great confidence, I think, when we're trying to choose this regimen for women with brain metastases. So this is looking at neratinib and capecitabine versus, I think what was very briefly the standard of care, lapatinib and capecitabine in these women. And these are oral therapies, so there's some ease in use there, which I think is attractive to patients. The overall response rate, progression-free survival, and median overall survival was slightly better with neratinib and capecitabine. There was a significant amount of side effect burden, which was mostly GI. So these patients can have a lot of diarrhea. I want to say over 85% of these patients or so experienced diarrhea on the NALA trial, neratinib and capecitabine. So we'll be really aggressive in the clinic, treating them with Imodium ahead of time and making sure that they have access to that. So for this reason, this option is probably 4th line or so for women with HER2 positive disease. It depends on the side effect profile and the patient right in front of you. But so as we were talking through these therapies, part of the difficulty is trying to put the drugs in order. And a lot of the way that we think about that is, who is the person sitting in front of you? Are they on oxygen with terrible COPD already? Have they been a lifelong smoker? Well, that may influence you maybe away from TDXD, or at least away from it initially, since any kind of hit in that area could be really damaging for your patient. Does the patient have CNS disease with their HER2 positive breast cancer? If so, then we're going to lean towards the HER2 CLIMB regimen with tucatinib, or even towards TDXD, which has shown activity in those women. So thinking about the side effects of the drugs, also thinking about whether IV or oral therapies are more attractive to our patients, but also recognizing that the goal is for, we know these patients are not going to be cured. The goal is for them to be exposed to all of these therapies as long as they can tolerate them over time. So really thinking about this is not rocket science to oncologists, but really thinking about the patient in front of you and what their preferences are and what would make them feel best. So question along these lines with HER2 positive disease: a 56-year-old woman with a 2-year history of metastatic HER2 positive hormone receptor negative breast cancer. Patient's really healthy with no significant comorbidities. She was initially treated with docetaxel, trastuzumab, pertuzumab. She's currently on trastuzumab deruxtecan, or TDXD. She's initially responded really well to that drug, but recently started complaining of headaches and nausea. So you're smart, and you get brain MRI, which shows new brain metastases, but also progression in her liver. So what treatment do you recommend next for this patient? A, trastuzumab and chemotherapy. B, trastuzumab emtansine, aka TDM1. We cannot name our drugs consistently. C, tucatinib and trastuzumab and capecitabine. Option D, neratinib and capecitabine. Or option E, pembro and chemotherapy.
Outstanding, Dr. Colonna. Thank you very much for taking us through options A, B, C, D, and E. We appreciate that. Audience, the poll has popped up on your screen. Please take a moment to make the selection that you think best answers this question for this patient. We had a question in the chat about making these slides available later on. We certainly will. In fact, they're available right now. So if you go to the handouts tab on the right side of your screen, you will be able to see today's presentation, Breast Cancer Evaluating, it starts with. You can preview that, download it, and use that for future reference so that you will have great information to be able to share with your colleagues and to use in the future. Dr. Colonna, we had a comment and a question about adverse events for some of our newer therapies. Can you take just a moment and comment on adverse events?
Yes, I think the question was specifically about neurocognitive adverse events.
Correct, thank you.
And I think it's a difficult question. I mean, we know the concept of chemo brain exists, but we largely think of it as, I think of it largely as like a cumulative burden from many therapies, plus also radiation, which can often be to the brain. So I never discount it when my patients are telling me that that's happening. It's harder to know exactly which drug or which thing, or is it the fact that we make everybody postmenopausal and we know that that has neurocognitive effects. But aside from probably the hormonal menopausal effect, I don't think of them any really specifically in that area. I don't know, Dr. Mizell, does anything pop to mind?
Oh, I'm still muted, Dr. Mizell.
I'm a good lip reader, but I'm not that good.
No worries. No, what I was going to say is I think other than endocrine therapies where we do see a lot of, that kind of slowing that maybe comes a little bit with putting people into permanent and sometimes, very intense menopause with ovarian suppression. Sometimes chemo brain can be a thing. And it's so hard to characterize that and fully diagnose it. But I sometimes will talk to patients about different options for that. Pharmacologically, some of the things I found to be helpful actually are low doses of some of the stimulants we use for adult ADHD. Ritalin and Concerta have been helpful to some of my patients where that's been a real struggle. And Provigil too can sometimes be helpful. But then often it's also the effects that our drugs and just like the anxiety of having chronic cancer can have on sleep. And if people are not sleeping well, they might not feel as cognitively sharp. So it's a complex one. And one of the, I think, side effects of just cancer in general that's hardest to treat.
Yeah, certainly is complex. Thank you. All right, the results are in. And the large majority of our respondents, 52%, have selected option C and as the number one choice. And then it's, I would say it's a bell curve, but it's pretty flat on either side. So 52% looks like the answer. Dr. Colonna, Dr. Mizell, what do you think?
Yeah, I think I won't belabor this point too much because I know we've got a little bit more to get to and not a ton of time. But I think with the HER2 CLIMB data, tucatinib really showed such benefit for patients with CNS disease, and that trial enrolled a really ambitious number of patients who had brain metastases. So in this situation where the patient's already had TDXD and now has new brain involvement, I would go with option C as well.
Outstanding. Thank you. Mm-hmm. Okay, as you noted, we'll keep moving. Dr. Mizell.
Dive right into triple negative. So I think many of you who've treated triple negative breast cancer before know that there's some big challenges in treating this disease. We have few well-defined molecular targets. Patients generally respond pretty well to frontline chemo, but we have high rates of recurrence and metastasis, which characterize this disease. And when patients develop metastatic triple-negative breast cancer, their outcomes are often very poor. The good news is that novel targeted therapies and immunotherapy have improved outcomes some. We want to talk today about some of those updates. So I think one of the biggest ones is the inclusion of immunotherapy for patients with neoadjuvant treatment of breast cancer. So for patients with stage 2 or higher disease, adding pembrolizumab to chemotherapy has now become an option. I won't belabor the actual regimens. I'm happy to talk about that more. And of course, you can look it up with the Keynote 522 reference here. But basically, this was a trial that took patients with stage 2 or stage 3 breast cancer, randomized them to receive chemo plus placebo or chemo plus pembrolizumab with 27 weeks of additional placebo or pembrolizumab after surgery. And these patients did much better, as you can see here, with the pembrolizumab added in terms of their PCR rate and also their event-free survival at 5 years, which, as you know, with triple-negative breast cancer is a very clinically relevant endpoint. So pembrolizumab was approved and was added to our treatment algorithms. I think one of the important things is that there have been other studies as well of pembro plus chemo. Keynote 522 looked at a pretty aggressive chemotherapy regimen, and some patients who can't tolerate all that chemo can still get significant benefit from chemo plus pembro in many forms. So we can talk that through, but I think that's an important point and something that has changed the landscape significantly. Similarly, we talked about genetic testing already and the importance of BRCA testing. The Olympia trial was a trial that looked at olaparib as an adjuvant therapy for patients with BRCA mutated HER2 negative early stage breast cancer. So patients with hormone positive HER2 negative breast cancer and triple negative breast cancer were included in this trial. And what this trial did was it randomized patients after they already received their chemo, surgery, radiation, whatever was felt to be applicable by their treating physician, and endocrine therapy. They were randomized to receive 1 year of placebo or 1 year of olaparib. What this study found was that for these BRCA mutation carriers, patients who received 1 year of olaparib did much better in terms of their invasive disease-free survival at 4 years, which is a relevant endpoint, but then also the very small, clinically small, but relevant benefit in terms of survival at 4 years. So olaparib as a single agent, 1 year has been approved for patients who meet criteria for the Olympia study, and it kind of highlights the importance of testing, doing genetic testing for patients when they're first diagnosed, because it might change their treatment plan. This is looking at an advanced and metastatic triple-negative breast cancer, a huge topic, obviously. For these patients when they're newly diagnosed with metastatic disease, we do germline testing right away for BRCA mutations, because we know that if they're positive, they might benefit from a PARP inhibitor in the metastatic setting. And then we also do CPS testing for PD-L1. The reason for this is that there's another Keynote study, Keynote 355, which led to the approval of chemo plus immunotherapy for patients for frontline metastatic triple-negative breast cancer therapy. But the catch is here, it's only for patients who have CPS scores greater than or equal to 10. So again, the importance of communicating with pathology and getting that kind of information for patients so that you can pick out who's going to be a candidate for pembrolizumab in the front line for triple-negative metastatic disease or not. So for these patients, they would go on typically to get their chemo immunotherapy if they are CPS positive and BRCA negative. If they are CPS positive and BRCA positive, I would probably give chemo immunotherapy first and then use PARP inhibitors later. And then for patients who are BRCA negative and CPS negative, they would go on to get chemotherapy. And there are a whole host of chemos you can give. I think weekly taxanes are often some of the most effective and best tolerated, but there's certainly an art to this. And for patients who don't want to lose their hair, for example, CarboGem is a very useful combination in that setting. We can certainly talk more about that. So this is looking at the Keynote 355 data, and as you can see here, for the patients who had CPS scores greater than 10 enrolled in this study, their median progression-free survival was significantly better with immunotherapy than without, and it was this group of patients that really drove the benefit overall in this study, and so that's the group of patients for whom chemoimmunotherapy in frontline for metastatic triple-negative has been approved. This is just looking at immunotherapy toxicities, and I think as breast cancer providers, it's been something that we've really had to get on top of and learn about. In some ways, we lag behind those of you who treat lung cancer and bladder cancer and other diseases where we've been using a lot of immunotherapy for longer, because in breast cancer, we've just started to have to learn about this stuff in the past few years. So I won't belabor these points given our timeline here, but you guys will have these slides, and this is just a really nice reminder of how many different organ systems immunotherapy can impact. So for managing immunotherapy-associated toxicities, of course, you have to know to look for them. I think one of the key things we do differently in terms of monitoring are thyroid function, adrenal and pituitary function during treatment. Here we typically are checking those with every cycle of pembrolizumab. And then in terms of management, steroids are often very helpful for managing rash, for managing pituitary dysfunction, other things like that. Often we have to give thyroid hormone supplements for patients who become hypothyroid on chemotherapy and immunotherapy. And then sometimes we see hepatitis, dermatitis, other things where, again, the steroids are important. And for many of these patients, you can start the steroids and patients can do well. Sometimes you can delay the immunotherapy and even restart it. But there are patients for whom, if they have severe adverse events related to the immunotherapy, you may have to discontinue the immunotherapy altogether. And then in very rare cases, do additional immunosuppressants beyond steroids. Switching gears to talk about PARP inhibitors, this is looking at two studies, Olympiad and Embraca, which led to the approval of two different PARP inhibitors in the metastatic setting for patients with BRCA-mutated breast cancers. So Olympiad looked at olaparib and Embraca looked at talazoparib. You can see that the outcomes are really pretty much the same in terms of significant improvements in response rates compared to standard chemo, several month improvement in PFS, and to date, no improvement yet in overall survival. So these do represent options for patients with advanced and metastatic BRCA positive, HER2 negative breast cancer. I was saying before that if a patient is BRCA positive and CPS greater than 10, I would still probably go with chemoimmunotherapy first because that improves survival, whereas this option doesn't necessarily improve survival, but does improve progression-free survival and is very well tolerated. But most patients who are BRCA mutated are going to see both of these. So again, just good options to have. And then this is looking at PARP inhibitors and side effects. And I think that the most important things to note here is that these drugs can cause cytopenias in all patients, maybe a little bit more in talazoparib than with olaparib. And then nausea and vomiting and GI side effects are a little bit more prominent in patients on olaparib. So important just to warn patients about these side effects and talk to them about it so that if they experience them, you can get on top of them right away. And then this is just looking at the VA kind of clinical pathways approaches for patients after they've received those therapies. So if they're HER2 low and triple negative, or hormone negative, HER2 low as we would call them now, TDXD is certainly an option for these patients. Sacituzumab govitecan, which we talked about in the hormone positive patients, is also an option here. It has data to support it a little bit earlier on in patients who have triple negative breast cancer. So we looked a little bit already at the Destiny Breast 04 trial, and I won't belabor this point, but basically that patients with hormone positive HER2 low or hormone negative HER2 low derive benefit from TDXD or physician's choice chemo. So certainly an option for those patients formerly considered triple negative. And then the Ascent trial looked at patients with, this is a phase 3 trial, although there was the earlier phase trial, the Immuno 13201, looking at sacituzumab for patients with high risk metastatic and multiply recurrent metastatic breast cancer, basically showing that patients who have had at least 2 prior treatments, including a taxane, are likely to have a much better response rate, progression-free survival, and even overall survival with SASI. So whereas some of these numbers were a little bit less pronounced in terms of the differences for patients with hormone-positive disease, for patients with metastatic triple-negative disease, we see much more benefit for patients who receive SASI over chemo. So we do use this a lot in our triple-negative patients. So nice to have additional options there. I think still much more to come and many more advances on the horizon. But we'll go ahead and just talk a little bit with Dr. Colonna about patient-centered care to improve outcomes, and then we'll wrap up.
Yeah, so we've alluded to it lots of times, but it's not just about what we know about cancers, but what are our patients choosing and what are driving those choices. And I'm not telling you guys things you don't know, but the most important thing is just to get to know the person in front of you, right? Who are they? What matters to them? What doesn't matter to them? Does their hair matter, not matter? And those things really drive a lot of our choices. But the challenge for us, I think, is distilling all this literature that we like to read about in these conferences and trying to distill that and make that make sense for patients and put that into a few discrete options, like 2 or 3 choices for patients. I think that's, that's the magic of being a medical oncologist is difficult. But I also think sometimes we use this as an excuse to sort of abdicate our responsibility, which is really to give them a recommendation. So I always try to be really clear, these are the options. You can do nothing also if you want, but I recommend, option A or option B and why, because patients are overwhelmed by a lot of this and they are looking us to guide them. So we want them to have some control, but we also want them to feel like that, they're not being left alone to make this decision. And then, as we all know, it takes a village to do this, to take care of these complex patients. So making sure that they know that these side effects are probably coming, and making sure that they have a host of resources that they can reach out to when these side effects become a problem for them. Clinical pharmacists, palliative care. Most VAs or many VAs at this point have palliative care teams that we should partner with alongside of us to help take care of these patients. This is where I think someday maybe apps and PRO tools could be really useful. We know those are shown to improve outcomes, actually, if patients are able to get access to those. And then just, again, thinking about the whole team. In the VA in particular, I think our social workers have probably improved outcomes more than I ever have. If a patient can't get to treatment and they don't have a safe place to sleep at night, they're not going to be able to do their breast cancer therapy. So making sure that we are aware of those needs that our patients have and then knowing how to connect them to the right resources. It's really important. It makes a world of difference for our patients that need support to get through what treatments can be really hard.
Outstanding.
Space if there's any questions, or Doug, if you got anything else.
Right on. Well, we'll move to our wrap up in just a moment and share with our audience how to receive credit for attending today's program. Dr. Colonna, thank you for your discussion around the patient-centered care and this multidisciplinary approach. Dr. Mizell, anything that you would add from your clinic experience or in engagement with patients that would help in coordinating multidisciplinary care?
I think just communication is always important, and I find my clinic runs so much more efficiently if I sort of anticipate what some of the questions are going to be and look at them on the back end. I am often emailing pathologists or radiologists prior to seeing a patient to get a little bit more insight on what they're actually seeing and reporting, so I can kind of give my patient the real inside scoop. I think from a patient care standpoint, just understanding what your patient's priorities are, what's going on with them, and what might scare them in terms of side effects and things like that can help you best choose treatment plans for them. And just being as open and honest as you can with what you think their prognosis is going to look like so that they can plan going forward. But it's great to have all these new options for patients, and really a pleasure to see patients respond to treatments we didn't have several years ago.
Absolutely. It is great. And Dr. Colonna, you mentioned pharmacists. As a pharmacist, I'll put a plug in for the clinical pharmacists on the team. To make use of our good friends who are there to help and can provide support to you and to your patients. Well, this has been an excellent program. If you've noticed on your screen, there's a pop-up where you can receive an additional 0.25 CE hours of cancer therapy information. So we refer you to that. Just click on the link if you would like to have more information. And we remind you that today's program is available via the handouts tab, and you will be able to download today's slide deck to use for future reference, and which I think is an excellent reference.